All right, welcome everybody. Thank you for joining our Managing Incontinence as We Age lecture. Thank you for those of you who are finding your way here through YouTube, and for those of you who may be joining over the phone, we're glad to have you. As a reminder, I'm Jasmine Chandy. I'm the program coordinator for Rush Generations. And a couple quick reminders before we get started. So if you're joining in on YouTube, if you have any questions or comments for our speaker today, you can type them into the chat box. So if you've joined in on your computer, you'll see that live chat button at the bottom of your screen. If you're on a tablet, you might see that button on the right side of your screen, but either way, you'll see a live chat button and you can type in any questions or comments for our speaker throughout the lecture, and then we'll share them at the end. For those of you who are joining in over the phone, we will have an opportunity for you to unmute yourself and ask a question if you have one at the end as well. So we're going to go ahead and get started, and I'd love to introduce our speaker for today. We have Dr. Sarah Adelstein, and Dr. Sarah Adelstein is the medical director for urology. She's also an assistant professor and, of course, a physician as well. And I'm going to give her a few minutes to introduce herself as well, and then you can take it from there.
All right, thank you. Can you hear me okay? Great. Okay, well, welcome. Really happy to be here talking to everybody about incontinence. It's a huge part of my practice, so I'll try to keep it to an hour. How's that? I want to talk a little bit about the pelvic floor and just kind of anatomy and a little background. And then I'll talk about the kind of like three most common types of urinary incontinence. So there's overactive bladder, which can cause urgency incontinence. We'll talk about stress urinary incontinence, and finally overflow incontinence I'll mention briefly. I have no disclosures today. And as I mentioned, so we'll talk about pelvic floor, the different kinds of incontinence, and I'll definitely spend some time on like what can you do at home to prevent and treat incontinence, and what kind of help can you get from physicians, and providers, and like what kind of treatments are out there. So I'm a urologist, and I specialize in urogynecology, which is also called female pelvic medicine reconstructive surgery. So I diagnose and treat pelvic floor disorders. I do urethra and bladder surgery. I treat urinary fistulas and also complications of vaginal mesh. I have lived all over. I did my urology training in New York. I did a fellowship in Seattle, and I've been at Rush, and I also see patients at Rush Oak Park. I've been here for about 3.5 years. So it's been other than like the pandemic, has been a lovely experience to be settling down in Chicago. So without further ado, the pelvic floor is a group of muscles, ligaments, and connective tissue that work along with your pelvic bones to hold in and support the internal organs. So we've probably all heard of the levator muscles, right? The levator ani muscles, including the PC or pubococcygeus muscle. And these are the muscles that we use when we do a Kegel exercise. And in the picture, they're this little pink strip of muscles there, okay, that again are supporting the bladder, the rectum, and in women, the vagina and the uterus as well. These muscles stabilize the pelvis and the hip. They're part of the core, right? So the pelvic floor works with your abdominals, your obliques, and your back to do most, right? Like standing, sitting, running, like kind of most activities that we do every day. They also have a really important role in women in pregnancy and childbirth. And here's one view of the pelvic floor, and you can get the sense it's sort of like a bowl or a hammock, okay? And because it's supporting the organs I mentioned before, it is involved in urination, it is involved in sex for women, and it is involved in defecation. And so when there are pelvic floor problems, all of those functions can be impacted. This is a picture from the other side, all right, from the bottom. And again, just we see that bowl of muscles, that provide all the support against gravity, okay, to hold everything inside. Do men have a pelvic floor? Yes. All right. So here's a man's pelvic floor from the bottom. All right. There's no vagina and uterus, obviously, but they still have a bladder and a rectum, and they urinate and defecate just like women. And so pelvic floor dysfunction can impact men's urination and bowel function as well. So pelvic floor disorders are a group of conditions that impact the pelvic floor. and prevents the support that your organs need to work effectively. All right. So the kind of pelvic floor disorders include urinary incontinence, which we're going to talk about today, fecal incontinence, pelvic floor muscle dysfunction, which is usually a pelvic pain problem, pelvic organ prolapse, which is sort of a hernia, right, in women. And all these pelvic floor disorders are generally caused by weakened muscles or tears in the connective tissue. And health conditions or injuries that impact the nerves controlling those muscles, for example, multiple sclerosis or sometimes Parkinson's disease, right, can impact the pelvic floor as well. Pelvic floor disorders are not a life-threatening condition, right? No one ever died of incontinence or pelvic organ prolapse, but they're obviously major quality of life issues because they impact our everyday function, how we move through the world, right? Everyone pees every day. Everyone has a bowel movement most days, okay? And then also huge impact on sexual function and psychological function, how we feel about ourselves, right? So risk factors for pelvic floor disorders, and I'll bring these kind of things up through the talk, but if any of these things apply to you, these are reversible things we can treat, all right, to kind of decrease the risk that you'll develop a pelvic floor disorder, okay? So hormone replacement, weight, right, like obesity and being overweight, tobacco, okay? Kind of like a heart healthy diet and a high fiber diet. Stress, right? Anxiety, stress, constipation, that's a big one. Medical problems, including lung diseases like COPD or asthma, diabetes, out of control diabetes has a big impact on the pelvic floor, Parkinson's disease I mentioned. All of these things can impact pelvic floor function. So I think I've worked this in when we're talking through the different kinds of urinary incontinence, so we'll come back to especially like related medical conditions. All right, so let's talk about overactive bladder. Do you spend a lot of time thinking about urination? Do you ever fear that you will leak? Okay. Do you plan your day around bathroom locations? There's this really lovely map of all the public restrooms along the lakefront, which they might not all be open this year, but hopefully next year they all will be. You may have overactive bladder. Okay. And overactive bladder is that kind of gotta go urge immediately followed by a leak. And sometimes it's progressed to such a point that there's no warning, right? The leaks just happen totally out of the blue with no obvious trigger. So normally when the bladder has a little urine in it, but not very much, it's sending a little signal to the brain to just let it know there's something there. And once it gets full, that signal's a little louder and says, hey, we're full, it's time to go. In overactive bladder, all those signals are amplified way out of control. So a bladder that's not very full is sending a really big signal to the brain. And boy, when it gets full, it is screaming at you, okay? And that's pretty anxiety provoking for the brain that's receiving all these signals. So urinary function, urgency, right, is a place where that mind-body connection is very strong. So I mentioned stress and anxiety. When we are not doing well, experiencing grief or depression or just having a bad day at work or with the kids, these kind of symptoms get amplified. Okay, so it's a place where the stress our mind has is being felt in the body, and also the body symptoms are really having an impact on the state of our emotions and mind. Those signals that the bladder sends to the brain travel through emotion parts of the brain, attention parts of the brain, all of these kind of like executive functions that you wouldn't, like animals urinate, right? You wouldn't think it's that complicated, but it really is involved in a lot of different brain areas. And we know from research that when people treat their overactive bladder, the brain function actually changes, which is pretty amazing. Like treatments that are targeted on the bladder are having an impact on the mind. So we know this is real. Why does overactive bladder happen? It is more common with advanced age. It is more common in women. It is more common after menopause, okay, or if there's at a young age, hormonal treatments like breast cancer treatments, okay, are a risk factor for this kind of thing. Bladder outlet obstruction, we usually think of as a problem in men, right? Men with big prostate can get overactive bladder, but also women who have had pelvic surgery and especially incontinence surgery, right, can develop overactive bladder symptoms. Metabolic conditions, especially diabetes, can lead to overactive bladder, and then neurologic conditions like we mentioned before, multiple sclerosis, Parkinson's being a couple famous ones. How do you treat overactive bladder? There are conservative treatments, there are medications, and there are also procedures for overactive bladder. Conservative treatments would be behavioral modifications, and I'm going to spend a lot of time talking about those in the next few slides. Pelvic floor muscle training like Kegels, urge suppression is a technique we'll talk about, and again, related medical conditions, right? If you are diabetic and your hemoglobin A1C is 14, your bladder is not going to be functioning normally. You get essentially a neuropathy in the bladder. So, optimizing related medical conditions is a really important part of the treatment strategy. There are medications, there are anticholinergic drugs. I'm sure we've all seen these advertised on TV, drugs like oxybutynin and sulfenacin, okay? That's ditropan and Vesicare that you've probably seen on TV. There are beta agonists like mirabegron and a new drug, vibegron, right? This is Myrbetriq and Gemtasa. So lots of different medication options, and then procedures, all right? There's a minimally invasive nerve modulating procedure called posterior tibial nerve stimulation. There's bladder botulinum toxin or Botox, and sacral neuromodulation, which is actually an implant, kind of like a bladder pacemaker. So lots of options. What can you do today to start managing overactive bladder? Is there a cure? Not really, okay? But if these kind of conservative treatments are taken pretty seriously, that's actually probably the closest thing to a cure, right? Optimizing those other medical problems and making some lifestyle changes at home. So what do I mean by that? So fluid modifications is an easy place to start. Lots of people talk about how you need 8 glasses of water per day. And I would remind you, we mean like, 8-ounce glasses, not, so for a total of like 64 ounces. Some people come in and they're having accidents and peeing very frequently. And it turns out they're drinking, over 100 ounces a day. Almost nobody needs that much, okay? The goal for your hydration should be to have pale yellow urine, right? If your urine is gold, you are dehydrated. If your urine looks like water, you are probably drinking too much. Some fluids are harder on your bladder than water, and that's what I mean by these bladder irritants. So I think about caffeine, coffee, tea, although herbal drinks probably can do a little bit of irritation to the bladder. Sugary drinks like juice and soda, even artificial sweeteners. Acids, including citrus and carbonated beverages like seltzer. Alcohol, spicy foods, chocolate, some people would include. So those fluids, it's kind of like you get an extra point, okay, compared to the same amount of water in terms of urgency symptoms and overactive bladder type of symptoms. So pelvic floor muscle training. So we all know about Kegels. We've heard of Kegels. Kegels are really a strengthening exercise, and I'll talk about them more a little bit later. But that same pelvic floor muscle contraction can be used to treat overactive bladder. Now, Margaret Morris was a physiotherapist in the 30s, okay, who first described these pelvic floor contractions. And over 10 years later, an American gynecologist, Dr. Kegel, widely published these. And so I always like to give a little dig that it was actually invented by a woman, but popularized by a man, okay? And what these exercises are, so, if you do a squeeze with the pelvic floor muscles, that can be used to strengthen the muscle. But the other thing you can do is this quick flick, okay, which is a technique for overactive bladder. You do little pulses, okay? And I think about, in men, I like to describe this as you're holding a fart muscle, right? Most guys kind of know what I mean. And for women, it's squeezing and pulling in with those vaginal muscles. Some women can do this, some women can't, okay? And especially after, menopause, after babies, it can be really difficult to control these muscles. It's not like, flexing your bicep where you can see what you're doing and you're contracting. Many folks need to work with a pelvic floor physical therapist to get good control of these muscles. Okay. But if you're able to squeeze them at home, you can do little pulses. That's kind of like 1, 2, 3, 4. Okay. Like a series of short squeezes, and that will actually send a signal to your bladder to calm down an urge episode. Good thing to know about. Urge suppression is a technique where, we think about that bladder urge feeling as coming in a wave. Okay, so the urge starts, it kind of builds, it gets really strong, and at the peak, if you were stuck in the car, it wouldn't stay at a 10 out of 10 severe urge the whole time you're driving home, right? It'll last a minute or two, and then it will settle down. So urge suppression says, don't go pee when you're at the peak of the urge. Wait until it settles down, then get up and go urinate. And if you do that once, it's not going to fix anything. And in fact, you might pee your pants if this is something that happens to you. It could happen. But if you do it routinely and really start training your bladder, no, I'm not going to go, I'm going to wait a minute. You can start to have a less intense urge. Okay, the urge never gets to 10, maybe it gets to 5. All right, but the trick is consistency. And then there's all kinds of techniques you can use, like distraction, focusing on something else. You can try those quick flick pelvic floor muscle squeezes I was just describing. Okay, stand and breathe. This mind-body connection is sort of how we accidentally teach ourselves triggers like keys in the door handle, right? Pulling into the garage, water, coming from the faucet. Our brain and bladder have worked against us to learn that these are triggers for urinary urgency. So urge suppression is the way we dial that back, okay, and kind of regain some control and teach the bladder how to, not act like a cranky toddler demanding attention. All right. As I mentioned, right, during that growing urge phase, you can do those pelvic floor muscle squeezes and then wait a few minutes, not an hour, right, a few minutes. When your bladder is calm, then go to the bathroom. All right, other things you can do today for overactive bladder. Treat those related medical conditions, okay? So in diabetes, blood sugars that make their way into the urine used to be a major driver of urinary frequency, and in ancient times, that's actually how diabetes was diagnosed, okay, because there was sugar in the urine. So the goal for overactive bladder is to not have all that sugar in the urine, okay? We would love for everybody's hemoglobin A1C to be under 7. And there's some diabetes drugs that lower blood sugar by putting the sugar in the urine, and that may exacerbate some urinary symptoms. So if you take a anti-glycemic drug that ends in gliflozin and you have major urinary symptoms, talk to your doctor about that. Okay, talk to your primary care or your endocrine doctor about that option and see if there are alternatives. Obesity and the metabolic conditions that come with being overweight, such as high blood pressure, high cholesterol. These things impact the bladder as well, and also the production of urine, okay, which comes from the kidneys. So modest weight loss can help with urinary symptoms. Things that are good for your cardiovascular health, right? That good healthy diet and exercise can help with bladder symptoms as well. Constipation is a major driver of urinary symptoms. When you're constipated, if your rectum is sending a signal to your brain saying, I'm full, right, of stool and I gotta go, your brain does not have the 2-point discrimination to know that it's coming from the back and not the front. So you kind of got to go everything, okay? It's not that it's physically blocking anything. It's more that the nerves all talk to each other and the messages all get jumbled. So, my goal for folks with overactive bladder is to try to have an easy formed bowel movement every day or two. So have water, take fiber, use laxatives. We want to have nice, easy formed stools, okay? And ideally something in this kind of like type 3, type 4, right? Who knew there are all these types of stool? You want your stool to kind of look like this consistency, ideally, right? It's easiest for your rectum to handle, least likely to have fecal incontinence, and also least likely to interfere with your bladder function. So what if we're working with somebody who has, cognitive limitations or mobility problems, urge suppression, you really have to, be engaged, right? Pelvic floor muscle contractions and urge suppression are techniques where you really need to be able to participate, okay? Okay, so there are some caregiver-driven therapies for urinary incontinence. Scheduled or timed voiding is probably one of the more common ones. So, to try to put somebody on the toilet or on a commode first thing in the morning, maybe every 3 hours through the day, and just kind of try to prompt urination before it's too late and there's an accident. Can be a game changer in terms of urinary incontinence episodes. There are lots of mechanical devices that can kind of assist in management of urinary incontinence. Everybody's pretty much familiar with pads and diapers, but having a commode or urinal at the bedside, especially for nighttime problems. There are external catheters for men, like condom catheters. There's also external catheters for women. And this Bard Purewick, there's a picture of it over on the side of the screen. That Bard Purewick is recently approved by Medicare as a kind of device to assist with incontinence at home. And there's also a clamp for men, okay, for urinary incontinence control. So we talked some about constipation. Let's talk about fiber, right? I said we need water and fiber to help constipation. Women really should be getting 20 to 25 grams of fiber every day. Men need a bit more like 30 to 35 grams of fiber. And, having a little prune juice is not enough fiber for the whole day, okay? So when I think about high fiber foods, I think about these kind of things: lentils, split peas, black beans. And look at even these super packed fiber packed foods, right? That's not your full day's fiber either. Okay. So, raspberries, only 8 grams. So you would need 4 cups of raspberries. Okay. Which is doable. All right. But most of us kind of think we're doing pretty good with fiber, and we're usually not getting as much as we think. Fiber from food is great. It's also fine to use a supplement, things like Benefiber or psyllium, right? Metamucil, there's all kinds of fiber supplements on the market. And what I would say about them is start low, go slow. If you introduce a ton of fiber into your diet all at once, it's going to give you a stomach ache. So kind of gradually increase and let your body get used to it. And make sure you take it with water, okay? So the way fiber works is it goes into your stomach and it sucks everything nearby in your stomach into what will become the stool, the kind of like proto-stool. So that includes water, that includes food that you've eaten, and it can include medications. So be careful. Don't take this at the same time as your blood thinner. All right, if you're going to take a fiber supplement, separate it from your medications by a couple hours. Let's talk about toilet ergonomics. So the kind of toilets that are great for mobility and hips, right, that are pretty high off the ground so you don't have to sit down very far, unfortunately are really terrible for defecation. And most people in most nursing homes don't realize this. When you are sitting on a high toilet, your pelvic floor muscles, and here's that puborectalis muscle, it's like a sling that goes around the rectum, is too tight, okay? And it's actually squeezing the rectum, so it's difficult to get the stool out. So the squatty potty is a stool, right? Okay, that lifts your feet up so that your knees are higher than your hips. And that action relaxes the pelvic floor muscles and allows the rectum to straighten out. It's more like a squatting position, right? We evolved to squat and do a bowel movement in the woods, and that's how it works best, okay? So having the knees up higher than the hips for a bowel movement can actually really assist with constipation. Night urination is sort of a special symptom, and it's different than having kind of daytime urinary frequency. So the kidneys are responsible for making urine. It produces the actual fluid. The bladder is responsible for holding that urine until it's time to go. Sometimes at night, the kidneys are making too much urine, okay? I have an analogy of the faucet and the bucket. The faucet makes the urine, that's the kidneys. The bucket is the bladder, and it holds that fluid until it's time to go. Once it gets full, it's got to dump out, okay? So if your faucet goes on high overnight, if you have a metabolic condition that's causing your kidneys to make a ton of urine, that bucket's just going to fill up really fast, and nothing I do to your bladder is going to change that. So what can we do at home? Limit fluids for 3 hours before bedtime, okay? Because what goes in must come out. Try not to take diuretics late in the evening. If you have leg swelling or lymphedema and you go to sleep with legs that are way more swollen than they are when you wake up in the morning, right? Then what happened overnight is your body processed that fluid by producing urine. Okay, so if you go to bed with really swollen legs, that's going to contribute to nighttime urination. So what can you do about that? You can wear compression stockings. You can elevate your legs before bedtime. Sleep apnea causes night urination. Most people don't realize that either. So when you're taking a breath and it's blocked off, the heart stretches and it releases an emergency signal to the kidneys saying, get rid of fluid, we're in trouble. And CPAP blocks that from happening. Okay, so most folks will find night urination gets cut in half with CPAP for sleep apnea treatment. All right, and then metabolic syndromes we talked about, right? The sugar control, vascular health, all those kind of things help the kidneys function more normally so they're not trying to make so much urine overnight. When should you see a specialist? If there is blood in your urine, right? If you see red blood in your urine, you need to see a physician, okay? And specifically a urologist, okay? If you want to try a medication, if you tried all these strategies I gave you and you're still having a problem, that is a good reason to come and see a urologist or a urogynecologist, all right? Or if you've been on medication for years and it's really not doing much for you and you want to talk about advanced therapies, that is also a reason to come in. So medications available for overactive bladder, there's actually one over-the-counter medicine called Oxytrol. That's a patch. There's about 15 different drugs for overactive bladder. I mentioned oxybutynin and sulfenacin earlier. Trospium's another one. These all calm down those signals between the brain and the bladder that I was talking about to make the urgency less severe. And the goal is to have fewer accidents and to have less frequent urination overall. Mirabegron is a different drug class, but accomplishes a similar outcome: less frequent urination, less intense urgency. In the last few years, we've been learning, there's some concerning evidence coming out that anticholinergic drugs, like that middle category, the oxybutynin, sulfenacin, trospium, these kind of drugs, probably can have cognitive effects when they're used for many years. So I usually tell my patients, I think those are fine short-term drugs. If there's any alternative for long-term, that always makes me a little more comfortable. Okay. That is not true for mirabegron and the newer drug vibegron. Okay. Procedures for overactive bladder, also great long-term options that are not going to have any cognitive effects. All right. I mentioned that posterior tibial nerve stimulation. So here's a picture of that. It's this tiny acupuncture needle that goes in the ankle, and we do a very gentle electrical stimulation of that needle. You sit in the office for half an hour, you read a book. It just feels like a little vibrating, tapping sensation. It's quite comfortable. And the downside is, because it's office treatments, it's like coming into the office every week for 3 months and once a month after that. There's also bladder botulinum toxin. Botox is a medicine that it's kind of like a muscle relaxer for the bladder. Okay, so it stops those spasms, the overactive spasms from happening, and also blocks some of those signals going up to the brain saying I've got to go. Also, like, a local treatment, it lasts about 6 months, which is wonderful. It is covered by insurance. Downsides are it's possible to relax the bladder too much and not empty all the way, or have retention, or need catheters for several weeks. Okay, so it's not a permanent treatment. It does wear off, but it does take some time. And then finally, sacral neuromodulation, which is an implant. It's a surgery where we put this little kind of pacemaking electrode into the sacrum, and it does a similar thing to the nerve therapy, except once it's implanted in you, it's active all the time. So, you get it implanted, you go home, and the therapy is active, and these batteries last for many years. All right, so that was overactive bladder. Now we're going to switch gears and talk about stress urinary incontinence. Stress urinary incontinence is the kind of leakage that happens when the pelvic floor has become weak. So anything that increases abdominal pressure, from above the bladder can cause an accident. So the urinary sphincter is the control muscle. It's sort of like a valve, all right? And so when coughing, laughing, sneezing, jumping, these things, when they overcome that valve because the valve is weak and causes an accident, that's stress incontinence, okay? So why does stress incontinence happen? Again, more common with older age, more common in women who have had multiple pregnancies or vaginal deliveries. In men, this is more common after prostate surgery, very rare to have in men who have not had prostate surgery. Pelvic surgery or radiation can lead to this kind of symptom. Pelvic floor muscle weakness, or even high tone pelvic floor problems, okay, like that pain condition I mentioned before, can cause stress incontinence. Chronic pelvic floor stress, so somebody who's had, lifelong poorly controlled asthma, or somebody who has COPD, or smokers, people who are chronically coughing, that is a chronic stress on that pelvic floor that can cause weakness and deterioration over time. Professional athletes like gymnasts also just have a lot of extra stress on this pelvic floor muscle group. And so all these folks are at risk for stress urinary incontinence. How do we treat this kind of incontinence? Again, there are conservative treatment, there are behavioral changes, right? Like weight loss, right? Being overweight is also a chronic pelvic floor stress. Tobacco cessation, optimizing lung disease treatments or exacerbations, staying active and keeping fit. We'll talk about that a little bit. There are conservative treatments. There's pessaries you can wear in the vagina for incontinence. There's even a tampon that can be used for preventing stress incontinence. Physical therapy is another nice conservative treatment option. Or there's procedures, okay? So bulking injections, slings. We'll talk a little bit about the surgical options. So I mentioned staying active, okay? Sarcopenia means skeletal muscle loss. So the kind of, as we age, we lose some of those big, strong muscle groups, right? They get weaker, they get more frail. And as that happens, not only are we kind of like getting frail as a whole person, but the urinary control can also weaken, just direct effect from the pelvic floor muscle group losing muscle mass. So how do we prevent sarcopenia? Okay, that is a normal part of aging. Some combination of aerobic exercise, which could be walking, right? Could be running, could be jumping rope, but even just regular walking is great aerobic exercise. Resistance training and weightlifting, super important. I think this is gaining a lot of traction. Kind of in the lay press and public, that resistance training and weightlifting is super important as we age. And it doesn't have to be like, huge deadlifts with like, those huge bars you see those young guys, lifting at the gym. It can be small weights, but a regular part of the workout routine is super important. Balance training. And these are exercises that, can be done in a group class, can be done with, personal trainers. There's all kinds of videos online. But some combination of these kind of sessions a few times a week, really helpful for preventing the muscle loss of aging and important for preventing incontinence. So we talked about Kegels and pelvic floor muscle exercises previously, all right? And I kept promising I'm going to tell you about how to use that to build strength, all right? So let's talk about that for a second. So when you squeeze the pelvic floor muscles, and it feels like kind of a squeeze and a lift if you have good control, that's one Kegel, okay? And the goal, okay, like it says here, contract that muscle quickly for 1 or 2 seconds and then immediately relax all the way, all right? That's the short exercise. The long one is to contract and hold for, like a count of 10, okay? And then relax for probably a count of 10 as well. All right, so that's like one repetition. Sometimes, like an example of a regimen that a physical therapist might give is doing those things, 5 repetitions of each of these exercises, lying down, and then do it sitting, and then do it standing. Do that at morning, at night, and it's something like 60 reps a day. I mean, it's really like not a minor thing. It's not like I squeeze a couple times while I'm peeing, which, by the way, we don't really recommend for anything besides identifying the muscle. It's a lot of reps, okay, to kind of like build up strength in these muscles. So again, if you're doing like 5 Kegel squeezes a day, that's fine, but don't expect it to make a big difference on your urinary symptoms. I also talked about how it's really difficult for some women to have control to squeeze these muscles properly. So really common and really important to work with a pelvic floor physical therapist who's a subspecialized PT, right? Folks who do hips and shoulders have no idea how to do this work. It often involves vaginal touching, okay? This woman here is teaching biofeedback, where she's looking at a visual representation of whether those muscles are squeezing or not, whether she's doing the right action. And that helps folks kind of gain control over these muscle groups that they might not have good feedback on. There are also surgeries for stress incontinence. There's bulking injections, which are a little bit like collagen filler, okay, that women put in their faces. Okay, here's a urethra that's weakened, okay, and here's what it looks like after the bulking injection, okay, and this is what it should look like, okay, so you can kind of directly get the sense that that valve looks like it's really going to work and prevent an accident when somebody coughs. There are synthetic slings, okay, so little strips of mesh. And here's a strip of mesh right here, okay, kind of like going under the urethra there and hiding behind the pubic bones, okay, and here's another example, just a slightly different path. These mesh slings work like having a backboard. So imagine stepping on a garden hose on the grass versus on the driveway, okay? If you step on the hose on the driveway, it's going to stop leaking. If you're on the grass and the surrounding pelvic floor tissue is a little weak, you may stop the leak, you might not. Mesh slings are not the product that was taken off the market by the FDA last year, okay? Those were prolapse meshes, big sheets of mesh that were designed to lift up the bladder. These slings for incontinence are not lifting up anything. They're just a little backboard, okay, to help prevent the leakage. And these are still the most common incontinence surgery done in America, and also the most well-studied surgery as well. There are surgical options that don't use mesh, okay? So this autologous fascia sling means we use a piece of like your abdominal wall or your leg connective tissue to accomplish the same surgery, but they're much more invasive, right? With a bigger recovery and other surgical risks. There's also some older procedures. Birch Culpa suspension is a surgery that uses stitches to give support to the urethra, but it's an abdominal surgery. It's like, making an incision on the abdomen and doing a, open pelvic surgery. So that's done a little less often these days, just because it's more invasive. When to see a specialist? Again, blood in the urine, always come in. But if you've tried Kegels or you've tried some of these strategies I gave you, you're still having a problem, that's a reason to come see a physician. We'd be happy to give you a physical therapy referral. We could try incontinence pessary, as I mentioned, those devices that you wear in the vagina, or discuss surgical options. Overflow incontinence, I'm going to just touch on a little briefly here. Sometimes when somebody is leaking, it is actually a sign that their bladder is super full. Okay, and this is not the kind of thing you can know about yourself at home. It's something that actually the physician has to check. If your bladder is so full that there's nowhere for the water to go as the kidneys continue producing urine, sometimes that is causing leakage. Okay, that's called overflow incontinence. And it very much is like what's depicted in this picture here, where there's water flowing into the bucket is totally full. There's nowhere else for that water to go. It's got to come out. And if this were your bladder, you can imagine that, yes, if you coughed, you might get a little spurt, okay? If your bladder had a little spasm, you might get a little gush. But the underlying problem is that the bladder is full. In the people this happens in, they often don't have great sensation. So, they often don't realize that they're not emptying their bladder. All they experience is the incontinence. So what I can tell you about this is it's something your doctor's got to check. Sometimes this is the reason why the conservative treatments have not worked. It turns out the bladder's just not emptying. So how do you know you have this? It's really hard to know. I think there's not like a good reliable sign you could have at home that would tell you one way or the other. But certainly like straining or feeling like you have a weak flow, or you feel blocked or obstructed, like it's a red flag. But I'll tell you that folks who have overactive bladder, where, maybe there's an ounce or two in the bladder and the bladder's screaming at the rain, I'm full, I gotta go, right? When you have an ounce or two in your bladder, the flow is pretty weak when it comes out. And sometimes, because the sensory trigger is so low to send this major urge, people feel like they're not emptying their bladder because 10 minutes after they have voided, they feel like they got to go. But the kidneys are filling up the bladder slowly, continuously, and sometimes the urgency signals are that out of control, right? So even having symptoms like this is not a reliable indicator. The most reliable indicator is your doctor checking, either with an ultrasound, or by passing a catheter to check what's left in the bladder after urination. And that's how we know for sure, and that can kind of like help guide treatment. So what if this is you? What if you have overflow incontinence? Okay. Sometimes there are reversible causes of urinary retention. For example, you just had surgery, okay? And the anesthetic and just the kind of manipulation of surgery temporarily puts all the organs into shock and they don't empty. Okay, great. We let some time pass. We kind of optimize a few things. We can change medications, and that should resolve on its own. Constipation, again, all right, the constipation can really mess up the bladder function. Sometimes we treat constipation and all of a sudden, you know, the bladder's been just like in shock, not working, and all of a sudden you'll start emptying again. This is another thing that comes up in the around surgery time period. So another reversible cause of retention would be the constipation. Sometimes there's not anything we can do to reverse this. Sometimes, you know, after radiation or pelvic surgery or just, you know, many years of neuropathy from diabetes, the nerves and muscles do not work anymore. Okay. In those patients, catheters are probably the only answer, unfortunately. There are catheters people can wear that connect to a bag. There are catheters we can teach people to pass in and out of themselves a few times a day. But ironically, right, you know, people come in leaking urine, you know, saying I'm having accidents, and it turns out the problem is not emptying the bladder, and catheterizing a few times a day can actually prevent the leakage because the bucket never gets this full to cause a problem. So that would be, again, difficult to figure out on your own, but it is one of the types of urine leakage that we see, and that's one of the ways we fix it. So I think I actually blew through that pretty fast. So how about that? I would love to take some questions. I'm also happy to go back to some of the slides about things you can do at home, because there was a lot packed in there that is probably worth going over again. So, but I'll let you guys kind of guide me where I should spend a little more time.
That's wonderful. We do have a few questions and comments for you, but if you want to go back through that first, and because we still have plenty of time. So did you want to do that? And then maybe we can resume around 2 with questions?
That sounds great.
Yeah.
Okay. Let's see. So yeah, I think like these exercises, I feel like I never spend enough time on this in my office. So I'm going to say it again, because I think these are the things that can really help folks at home. So pelvic floor muscle contractions, again, it's sort of the, you know, if you're a woman, it's kind of like squeezing and lifting those vaginal muscles. And if you're not sure if you're doing it, one thing you can do is actually put a finger in the vagina, and you should feel the muscles kind of like squeeze down on your finger, or even pull your finger in a little bit, and then you know you're using the right muscle group. A lot of the time, women think they're doing a pelvic floor muscle squeeze, but they're actually squeezing their butt, right? So you should not be moving your gluteus muscles at all, or they're squeezing their abs, or sometimes they're actually pushing, like the way you would strain for a bowel movement. Those are common mistakes that come from, you know, like the control over those areas where there's a little tissue damage and nerve damage from having had babies and having gone through menopause, just kind of gets in the way. So if you're able to do this exercise well, you know you're stopping the flow of your urine, right? When you try it while you're urinating, then you can use these quick flick, you know, muscle pulses to help tell the bladder to settle down. In men, I again usually describe this as your hold in a gas muscle. Okay, that's also a pelvic floor muscle squeeze. Another pointer is, I mentioned a couple times now, don't actually do this while you're urinating routinely. The reason for that is, you know, your bladder wants to like have a nice normal void. And when you routinely stop your urination because you're practicing your Kegels, it actually makes your bladder feel like it's blocked, you know, by surgery or by a big prostate, or, you know, and it causes that bladder outlet obstruction picture I mentioned previously. So it actually can probably make bladder urgency symptoms worse over time, because it's training your bladder in a funny way not to empty well. So I don't recommend routinely doing Kegels during urination, but like once in a while to just double check, do I have, am I squeezing the right muscle? Am I doing the right thing? Yeah, great. But that's not the time to be doing your exercise regimens. All right, to look at these urge suppression techniques again. All right, so here's that nice urge wave, okay, where the urge to urinate it starts, it grows, it gets stronger, stronger. And at the peak, everyone's really tempted to get up and run to the bathroom, right? But they're like kind of like doing that wiggle on the way there, crossing their legs. And I think of the bladder, it's almost like a toddler having a temper tantrum. When you jump up at the peak of the urge and run to the bathroom, it kind of amps the bladder up, and it's more likely to behave this way next time. Okay. So urge suppression means instead of jumping up and running, wait a minute, let the urge settle down, right? And I'm not talking wait 2 hours, I'm talking wait a couple of minutes. And when the bladder is calm, that is the time to go urinate. Other strategies that can help you get through this urge wave are those quick flicks, right? Remember I said you kind of do like 1, 2, 3, 4, 5, and then take a little break, and you can do it again. And doing those muscle squeezes sends a signal to your bladder to calm down that urge wave, okay? And the urge wave is both a sensation that you need to pee, and sometimes it's actually the bladder muscle starting to squeeze and trying to initiate a void. All right, and both of those things get relaxed by this quick flick technique. The bladder squeeze or spasm that's happening during these kind of like urgency episodes, sometimes men and women can feel that shooting down the urethra. Okay, so it can feel like a cramp, it can feel like a stabbing pain, and people will describe feeling like there's something that's shooting down the urethra. That's usually a bladder muscle squeeze, and it's part of this overactive bladder spectrum of problems. So quick flick technique, you can use those distraction techniques, right? Call a friend, take out a word puzzle, right? But it's got to be something engaging. So in the very beginning of the talk, I mentioned how the bladder urge signals go through your attention circuits and your emotion circuits and all these different parts of the brain. So again, we can use that to try to settle things down. Another way we know this is true, right, is that lots of folks will describe, when I'm at work, when I'm busy, when I'm sitting, I am totally fine. It's when I get home at the end of the day, or when I kind of like get up and switch gears to do a different task, right? That's when the urgency symptoms kind of break through. And the reason for that is exactly because of the way the bladder signals go through our attention circuits, okay? So when our brain is shifting gears and not as focused as it was, a signal that is unchanged from 5 minutes ago suddenly becomes way more important, and it's sort of like it's shouting at you and it's harder to ignore. So again, we can use some distraction and focusing techniques to let the urge settle down and then go pee. All right, did I miss anything in here? We would say actually to be sitting, all right, is actually better than to be like kind of standing and, standing with your legs crossed, okay? But try to breathe, right? Keep breathing, relax your body, try those pulses to let the urge pass. Some people do all the things I just suggested and they'll still have an accident, okay? And if your overactive bladder is that severe, that's probably a good reason to at least try a medication to help you do this exercise. The other group of people that will struggle with urge suppression is the ones who their urgency is so advanced they don't even get the warning, right? They don't even get the signal. They're just minding their own business, and suddenly there's this big gush and the bladder has just emptied. All right, if you don't even get a warning, you're not going to be able to kind of participate in this exercise. But taking medication might slow things down enough that you get that little warning before you have a problem. Urge suppression is also helpful for night urination, interestingly. So even though you're probably asleep, right, before that urge happens and wakes you from sleep, if you were doing urge suppression really consistently during the day, there is still a benefit at nighttime. So let's say, it's for someone who urinates every 2 hours all day long and is up 5 times at night. If they really do this urge suppression exercise, they might find that they're not getting up at night as often because the benefit carries over to nighttime as well. folks have studied this technique, this urge suppression technique, compared to taking a drug, and actually found that it's equally effective. So I know I have now like drilled in on it quite a bit, but I think it is really underappreciated by most physicians and urologists, that this is as effective as taking a medication, and there are no side effects. So really worth spending a lot of time on at home if this is something you suffer from. All right, should we take a short break and come back to questions in a few minutes?
Yeah, we can do that. That sounds good.
All right. Should we do 5? I don't want to leave everyone hanging for 10 minutes.
Okay, sure. Yeah, so let's do 5 minutes. And thank you for those of you who've added questions so far. For those of you over the phone, we do have an opportunity for you to ask right now. Dr. Adelstein, did you want to take a break or did you want to go right into it?
Yeah, I'm happy to go right into it.
Okay, it looks like someone unmuted themselves, so just want to give them the opportunity.
Yeah.
Yeah, so for whoever joined over the phone and unmuted themselves, you're welcome to ask your question now. Did someone unmute themselves? All right. All right, that's all right. So for those of you who are over the phone, you're welcome to think about your questions now and unmute yourself and ask. And in the meantime, we'll jump right into the questions that we have. So first of all, you're getting a lot of great comments of just how well the presentation was. So just wanted to share that first. The first question says, first a couple of comments. One individual said, I've done Kegels, but problems persist.
Mm-hmm. Yeah, absolutely. So when folks are having incontinence and the problems persist, there's a few reasons that can happen, but I'll cut to the chase and say that's a time to come see a specialist, okay? But the things that I think about for why Kegels failed are, number one, are we treating the right kind of incontinence, okay? Because Kegels is a strengthening exercise, and if you have overactive bladder, that gotta go, strengthening your pelvic floor actually is not gonna fix the problem, okay? So we wanna make sure, first of all, that we have the right diagnosis. Second of all, we want to make sure we're actually doing the exercise correctly. I mentioned that a lot of folks think they're doing a Kegel, but when I examine them or a pelvic floor physical therapist starts working with them, it turns out maybe they're really squeezing the external muscles, right? The buttock muscles. And that's not going to help you stop peeing. And then finally, sometimes it's not enough. Okay, so that's when we get into some of our other therapies. Working with a physical therapist is far more effective at improving urinary symptoms than trying to do Kegels on your own. And then sometimes folks, need a surgical option in order to stop leaking. So if you've tried Kegels on your own and you feel like you kind of like checked all those boxes I talked about, then that's a good time to see a urologist or urogynecologist and talk through what else is out there.
Thank you. And it looked like someone had just unmuted for a moment. So if someone over the phone had a question you wanted to ask, you're welcome to unmute yourself now. And you can unmute yourself by pressing *67 on your phone.
Hello, Dr. Sarah, can you hear me?
I can. Hi.
Hi, so my name is Shweta and I'm a pelvic floor physical therapist, but I just recently started working and it's very hard for me to get in touch with urologists and to understand from urologist's perspective, like when we work in incontinence, what would you like to see from physical therapists? So we can work in coordination with, your expectations.
Great question. So when I'm trying to make a referral to a physical therapist, I try to always write the reason I'm referring someone, because I know you guys have, I'm describing my limited understanding of what you guys do. But I know physical therapists have like an armamentarium of different techniques they can use. And so I know if I kind of describe what I think the diagnosis is, then my patient's going to get the best benefit. So, right, like I think I spent a lot of time talking about like stress incontinence and pelvic floor muscle strengthening and training, which I usually describe to folks as, strengthening the pelvic floor and also supporting like the hips and all those core muscles that go into maintaining continence. If I have a patient with urgency incontinence and overactive bladder, I think physical therapists are great at going over some of those urge suppression techniques, as well as making sure we can do a quick flick appropriately. And the other thing I send folks to pelvic floor physical therapy for that we didn't really talk about today are myofascial pain, right? Where the treatment technique is almost the opposite, right? So like manual therapy to relax the pelvic floor muscle tension. And the other category would be folks with neurogenic bladder, so like kind of multiple sclerosis or spinal cord injuries. And some physical therapists have been trained in like crede and tapping and other techniques to initiate voids. I don't know, like I've learned some of what I know from physical therapists, right? About like the squatty potty. I didn't learn that in medical school. I learned that from physical therapists. So just kind of all these techniques I think are super useful, but hopefully the urologist is communicating to you why they're sending the patient so that you can kind of choose from your tools, what will benefit patients the most.
Thank you, Dr. Adelstein, and thank you so much for your question. That was such an interesting perspective. All right, so the next one, if you have a strong urge and it is very intense, you do the exercises on your way to the bathroom. Will this hinder the flow of urine while you are on the toilet?
No. But what I would say is, right, like in keeping with my urge suppression exercise, trying to squeeze while you're wiggling to the toilet is sometimes really amping your bladder up. So I would actually say, sit down, do your exercises and quick flick, right, pelvic floor pulses while you're sitting. And then when your bladder's calm, then get up and walk to the bathroom. But doing your exercises ahead of time should not make it more difficult to pee.
Okay, great. And then we have a comment for you that says, thank you, Dr. Sarah, for a very comprehensive presentation.
Oh, thank you.
Okay, and then what is a normal frequency to urinate each day?
There's not a great number that's a good average. And part of that is because it depends so much what you drink, right? Like some people drink more than others. Young people pee less frequently than older people, and that's normal, and that's just part of the kidney function that changes over the lifespan. It is not normal for like a 15-year-old to wake up in the middle of the night and pee, but it's pretty normal in your 70s and 80s to get up once or twice at night, right? It doesn't mean anything's wrong. It could be annoying, but it doesn't mean anything's wrong. So there's not like a one number that's normal for everybody. Most people don't drink enough that they need to pee every 30 minutes. I know sometimes I get patients coming in my office and they're like, well, I pee every 30 minutes, but I drink a lot. And I'm like, oh my God, like, are you drinking 5 liters a day? Because like, there's no way that sounds out of proportion. It almost always is. People who void every 3 or 4 hours are generally, doing okay, not having urination get in the way of their quality of life. And that's usually what I kind of shoot for that's like the goal, right? When I'm treating people for overactive bladder. But obviously, like some people pee every 8 hours, right? Like, so for some people, every 3 or 4 hours, like sounds crazy. But I think for people with overactive bladder, 3 or 4 hours is pretty good. 1 or 2 hours is not great. That's going to get in the way. So it's kind of a loosey-goosey answer, but kind of depends how old you are. It depends how much you drink and how much you hydrate. Depends if you take a diuretic, but 3 to 4 hours for somebody who started with a problem, I think is like pretty good.
Great. And we have 3 more questions. The next one, I heard spicy food can cause incontinence. Is that true?
Spicy food can be a bladder irritant. Okay, so not exactly that it causes incontinence, but some people find that spicy food is the trigger for that bladder urgency, and then that kind of urgency can lead to an accident. What I would say is not everybody's body read the textbook, okay? So some people find that spicy food is totally a trigger for their symptoms. Some people cut out all the spicy food and have exactly the same symptoms. Have your spicy food, that's fine. But I would just say play with it. Same is certainly true for seltzer. Seltzer is another one that like sometimes women cut out seltzer and they have a major improvement in their symptoms, and sometimes they don't. So if it doesn't, if you tried an elimination, period, and it made no difference, then have it. That's kind of my feeling.
All right. And then is there a connection between diabetes and incontinence?
Absolutely. Okay. And it's sort of a twofold connection. One, because if you're getting sugar in your urine, either because the sugar control is not good or because you're on one of those drugs that puts the sugar in your urine, then the overall urine volume is going to be high, so you're going to be peeing frequently from that. The other major impact is that you can get neuropathy in the nerves that control your bladder, just like you get neuropathy in fingers and toes or even in your retina, right? And so early in diabetes, an early sign of diabetes can be frequency, urgency symptoms like overactive bladder. And in later stages of diabetes, if the sugar control has been not good for many, many years, you actually can lose your ability for the bladder to squeeze, and people end up with urinary retention. Okay, so absolutely, diabetes impacts the bladder, and it's like another reason that good glycemic control and keeping that A1C under 7 super important for your urinary health.
All right, and our last question, can you re-explain sleep apnea and incontinence?
Yes, this always surprises folks in my office. Okay, so when you have sleep apnea, it's sleep apnea and night urination. That's the specific link. So when you are sleeping and you're kind of breathing and trying to take a breath, but your airway blocks that breath, okay, your chest stretches because it's trying to inhale. Your heart stretches and your heart says, "Oh my God, we're in heart failure," and it releases a chemical that tells your kidneys, get rid of fluid because we're in heart failure, okay? And it causes a diuresis, and it's like a release of fluid into the urine that only happens when you're sleeping, okay? So sometimes, if I have someone come in my office and they pee every 6 hours during the day, they have no problem during the day at all, but they're up 10, 15 times at night, or, wetting their pants on the way to the toilet, right? That's really out of proportion. And then I'm asking questions like, do you have sleep apnea? Do you snore? Maybe you need to be tested for sleep apnea? And in those kind of folks, CPAP will cut night urination in half because it blocks that process where the heart is getting stretched by the sleep apnea, the obstruction. And so that signal does not ever get released to the kidneys to tell them to make extra urine and get rid of fluid. Okay. I hope that answered a little better.
That's great, thank you. And I'm just going to offer one last opportunity for those of you over the phone. If you had any questions, you're welcome to unmute yourself and ask now. And again, you can press *67 to unmute yourself. Hi, did you have a question? Hi, I noticed someone unmuted themselves. You're welcome to speak now. All right, that's okay. Thank you so much, Dr. Adelstein, for your presentation and for answering all of our questions. We really appreciate it. Right now, for those of you who are with us, we're going to go ahead and start sharing some of our upcoming programs. So I'm going to go ahead and start sharing that now.
Thanks so much for inviting me, and everybody have a great day.
Thank you so much. All right. All right, there we go. So again, thank you so much for those of you who've joined. We're really glad you're here and that you stayed for the entire presentation. We're going to share some of our upcoming programs with Rush Generations. So first we have our Walk with Ease program. This is a virtual walking group, and it will be taking place on Mondays from June 28th until August 2nd. This is from 10 a.m. to 11:30 a.m. and it will take place through Zoom. So if you are interested in this, a really great way to stay engaged, stay healthy, and stay active. So if you're interested in this program or any other programs I'm about to mention, you can call the Rush Generations toll-free number at 800-757-0202. Next, we have a workshop for living well with chronic pain. So this is an opportunity for you to learn different skills and set goals on how to better manage your chronic pain by different adjustments to your day-to-day life. And so this will be on Thursdays from July 8th until August 19th from 1 to 3:30 p.m. This will also take place through Zoom. And so if you are interested in this program, but you haven't used Zoom before and you're not really sure how that works, that's okay. A member of our team can help you get comfortable with that before joining the workshop. Next, we have our Health Legacy program for women, and this particular workshop, this particular Health Legacy workshop will be in Spanish. And so this will be on Tuesdays and Thursdays from June 20th until August 26th from 3 to 5 p.m. And this will also be taking place through Zoom. Next, we have our Coping and Connection in the Time of COVID support group. So this is a monthly support group, the third Wednesday of every month from 3 to 4 p.m. And it takes place over the phone. So this is a really great opportunity for you to connect with other people just about the stresses and how we're adjusting to this new time and how it's changing. It's changing kind of every month, it seems. So if you'd like to join this telephonic support group, the number is on the screen, but you can also get the information by calling the Rush Generations toll-free number at 800-757-0202. Similarly, we have the Diabetes Education and Support Group. So if you want to learn more about diabetes, get education and more support around diabetes, this will take place the third Thursday of every month from 2 to 3 p.m. This is also taking place over the phone. We have that information up now, but also if you need the information, you can call the Rush Generations toll-free number, again, for the Diabetes Education and Support Group, the third Thursday of every month from 2 to 3 p.m. Next, we have our Senior Connections Friendly Caller program. So if you're interested in receiving a call once a week, this is a really wonderful opportunity to really make a connection and to just have a chat at a scheduled time that works for you every week. So if you're interested in the Senior Connections Friendly Caller program, you can call the Rush Generations toll-free number at 800-757-0202. Next, we have our Rush Caregiver Initiative. So if you're a caregiver or if you have a caregiver, this is a really great opportunity to get some customized approach. It starts off with an assessment of what the needs are, and then the Caregiver Initiative will come up with a really tailored plan to what will serve you and help you the best. So if you're interested in the Caregiver Initiative, you can call the Caregiver Initiative at 312-563-0350. Again, that's 312-563-0350. And last but not least, we have our Shaman Senior Voices program. So this is a really great opportunity to learn about what matters most to you and to talk about aging and our experiences. And so first, if you'd like to learn more about Shaman Senior Voices, you can visit aging.rush.edu/shaman, and I'll put that in the chat box as well. But this program is all geared towards learning what matters most to you as you age. And then we take this knowledge and we use it to educate our healthcare students, our providers, and have conversations about aging. And so one of the ways that we learn what matters most to you is through the use of video. So if you're interested in recording a video or watching videos that have been recorded before, you can follow this link. You can also use that code by opening up the camera on your phone and pointing it at that code. Or you can go to bit.ly/recordmystory to visit the recording page. You can also explore the website and see some of the videos that have been collected already. So a really great opportunity to hear from other people, maybe some familiar faces as well, and to learn more about the Shaman Senior Voices program. And then just a final reminder that we have a number of programs, workshops, lectures, fitness classes, support groups, and a lot of great ways to stay involved, to stay healthy, and to age well. So if you're interested, you can call the Rush Generations toll-free number for more information. Again, that's 800-757-0202. We also have a Rush Generations Facebook page where we post upcoming events as well as some other interesting tidbits. So if you're interested, you can explore the Rush Generations Facebook page or give us a call at the toll-free number for some upcoming programs. Thank you again for joining